All right, everyone, I think it's about time we should start. Welcome to the December edition of the Australasian Pleural series. Again, we are trying to provide a short, succinct lecture on a pleural topic, probably about 15 minutes, and then we'll allow question and answer. So for those joining us, can you start typing questions as you go along on the chat so that we can ask our speaker? So today it's our pleasure to have Agrawal from New York. So he's staying up very late, almost midnight, to come and join us. So thank you very much. He's recently led the consortium or the group that published the Delphi consensus statement on management of chylothorax in the adults in the ERJ. And that's quite a significant effort. So today he's going to talk to us about chylothorax, which is a topic that we see from time to time, a condition that's easy to miss and not easy to manage either. So we're going to remind you that this is recorded and we will be posting the video on YouTube afterwards. And if you have any questions, don't forget to put it on chat. Okay. Abhi, I'll let you share the screen and then.
Great. I just want to make sure everyone can see the screen and hear me okay. Great. Thanks, Gary. New York never sleeps, so it's never too late in New York, which is great. But thank you for the opportunity to talk about, Gary was an integral part of our recent consensus statement. So I'm going to talk about multidisciplinary management of chylothorax, as Gary mentioned, a topic or a disease state that is easy to miss, not very common, and therefore it's always challenging to manage as they come along. So I do not have any conflicts of interest for this specific talk. So what we're going to talk about today is both identify the conservative management and the definitive management options that we have if we have a patient with chylothorax. We will then talk about the conservative measures for both traumatic and non-traumatic chylothorax, and then evaluate the role of definitive management for both of these disease states. What we want to do, and what we try to do through this consensus statement is to come up with almost algorithmic multidisciplinary management approach for management of these challenging cases. So we all know chylothorax. Again, you have a patient with a pleural effusion. You can do a diagnostic thoracentesis, or in some cases, the patient has a chest tube, and now you're seeing this milky stuff come out, though that may not always be the case. But if you're suspecting chylothorax or you see this milky stuff, you're going to be sending triglyceride levels. Greater than 110 is the cutoff that is used. But again, if it is less than that, if the patient is NPO, you could do a lipoprotein electrophoresis and then diagnose. And I do want to talk more about management rather than diagnoses. So when we talk about management of chylothorax, it's extremely important that we distinguish the two types of chylothorax, which is namely traumatic chylothorax or non-traumatic chylothorax. And when we talk about traumatic chylothorax, the most common subgroup is the postoperative patients, some of that which, as pulmonologists or respiratory physicians, we may not see all the time, especially after esophageal or lung resection surgery. There's also trauma surgeons that will see blunt trauma injury or penetrating trauma injury that will present with the pleural effusion that is a chylothorax. But what we'll see most commonly is non-traumatic chylothorax, which could either be due to malignancies, the most common being lymphoma, or due to non-malignant disorders, lymphangioliomyomatosis, sarcoidosis, and other infections, tuberculosis being a common one. So this was a recent paper that was published out of Europe. This was part of the International Collaborative Fusion Database. And what was interesting was they had 12 centers. They reviewed the retrospective chart review for 77 patients. As we said, they had 73% patients present with milky fluid, 89% was exudative. But what I want to highlight is that the one-year mortality for these patients was 47% in that subgroup. And you can see that majority of those effusions were from underlying malignancy. But what they also demonstrated was that in terms of definitive management, when we talk about the options that we have, which include dietary measures, pharmacologic management, thoracentesis or chest tubes or the pleural interventions, thoracic duct ligation, or thoracic duct embolization, only 3% patients actually got a definitive intervention. And so this was one of the reasons, along with many others, that we came up with this consensus statement, which was recently published in ERJ, a multidisciplinary effort, including pulmonologists, thoracic surgeon, interventional radiologists, that tried to bring all the data that we have together to provide recommendations based upon a Delphi process. So what are the options that we have? Well, the first conservative option that we have is dietary management, and this can range all the way, starting from medium chain triglycerides, where you have a high protein, low fat diet with MCT. Then you can progress to nil paras or NPO, and then in extreme cases, you can consider total parenteral nutrition. And the success rate can range anywhere between 20 to 76%. But it's important to note that majority of the data that comes for dietary measures actually comes from post-surgical patients. And it is hard to say if one was better versus the other, because majority of these patients had a combination. So they would start with, dietary measures, but some of them would also get pleural interventions. Others would also get definitive surgical interventions. So it's hard to tease out exactly the efficacy of these measures. But what we do know as aggregate, and what we summarized in the paper, was that if you have a traumatic chylothorax, where this data comes from especially post-surgical patients, you can start with MCT diet, and then if the patients are not responding, especially in high volume chylothorax patients, you can then escalate to NPO and then even escalate to TPN. They did demonstrate that the success rate was better post lung resection. If you have a non-traumatic chylothorax, again, it is fair to try dietary measures. The limitation is that, especially for patients with malignancy, they tend to be malnourished, especially if they are on disease-directed therapy. And so therefore, dietary measures may be a little more challenging in that subgroup of patients, but something that we can start with, at least the MCT diet. And we do recommend a nutrition consult to help, guide the diet for the patients. Of course, these are always coupled with pleural interventions, as we'll talk about. The second conservative measure that we have for patients either that are not responding to nutritional therapy, or you're using adjunctive therapy or pharmacologic agents. And there's very limited data. The only drug that has a lot of data available is octreotide or somatostatin analogs. There are case reports for both midodrine as well as orlistat. When we talk about octreotide, there was one systematic review, which had 19 studies. And again, as we saw in the dietary measures, majority of this data came from postoperative chylothorax. And it did demonstrate that there was some success, but it was very variable. And the study qualities in the meta-analysis that was done was very variable as well. And so how do we bring that to our clinical practice? Well, unfortunately, there is very limited evidence. And the consensus in the statement was that it is not routinely recommended. Now, if you have a patient with persistent high volume chylothorax, can you use it as adjunctive therapy? In that subgroup of patients, it may be reasonable to try. It will be combined with tube thoracostomy and a diet. And if the patient is a candidate, then you're going to pursue a more definitive percutaneous lymphatic intervention. And if a patient is not a candidate, then in those subgroup of patients, you can consider as a Hail Mary, these somatostatin analogs, such as octreotide. So that brings us from conservative measures, and of course, pleural interventions also conservative measures, where these patients are either going to get a thoracentesis or a chest tube for symptomatic relief. But then when we talk about more definitive measures, we talk about number one option being surgical, which is VATS with thoracic duct ligation. And you can see here what they're doing is, if they can isolate the site of the leak, they're basically ligating the thoracic duct using a right-sided VATS approach. So what is the data for thoracic duct ligation? And again, it is extremely different when we talk about traumatic versus non-traumatic. So on the left of your screen, you're seeing postoperative chylothorax, and you can see that there have been multiple studies in patients who are appropriate candidates for surgery. Again, these excellent success rate, up to 90%, some patients with 100% success rate. But the data was very limited for blunt trauma, or true traumatic chylothorax from blunt or penetrating injury. When you talk about thoracic duct ligation for non-traumatic chylothorax, that's where the data starts becoming extremely limited and the success rate starts to drop down. And you can see that the success rate here may be as low as 60%. And we can imagine that a lot of these patients actually are poor surgical candidates, so they're not even going to the operating room. And then if they go to the operating room, the site may be very diffuse. The leak, especially in patients with malignancy, may be extremely diffuse. And so they cannot really ligate the thoracic duct, and they may have to do a mass ligation, which reduces the success rate. The other definitive alternative intervention is thoracic duct embolization. So here you can see a video from our colleagues at UPenn who are experts in thoracic duct embolization, where they're accessing the thoracic duct. And once they access the thoracic duct, you'll see that they will pass a catheter or access sheet. And once the chyle leak site has been identified, the sheet will be advanced into the target area. And then what they're doing is basically advancing a coil and coiling the thoracic duct itself. And this can be either used by itself as a coil, or a lot of cases, they will then follow that with glue to allow for further embolization and therefore cease the chyle leak itself. And so when we talk about thoracic duct embolization, you can see again in patients with postoperative chylothorax, most of them tend to have a single site of leak because either it's traumatic, from the surgical intervention. The success rate is pretty good, and especially if they achieve cannulation, which tends to be the hardest part in these patients when they're accessing the thoracic duct all the way from the inguinal lymph node. The success rate is pretty good. When we talk about thoracic duct embolization for non-traumatic chylothorax, again, the success rate is good, but most of these studies actually defined it as technical success and not clinical success. So what that means is they were able to access the duct, they were able to embolize, but that may not mean that the patient actually had cessation of chyle leak. And therefore, that may be an option where these patients may require a palliative intervention to follow. A lot of these patients, though, poor surgical candidates, right? So you're not going to be candidates for thoracic duct ligation. Then the only definitive option we have left, especially for a high output chylothorax, is thoracic duct embolization. And so therefore, there are larger studies for that subgroup of patients when we talk about TDE itself. So what do we do? Is it thoracic duct ligation or is it thoracic duct embolization? And that really comes back down to the etiology of the chylothorax. If it is traumatic, the approach is going to be different than if it is a patient with non-traumatic chylothorax. So let's start step by step. Let's start with postoperative chylothorax. This is something that is more commonly seen. You're going to have a patient that already has a tube thoracostomy postoperative from the OR, and now you can see that there is a significant chyle leak. You're going to start with conservative measures. If it is a low volume persistent chylothorax, then these patients may not need to go back to the operating room, and what they can do is do a lymphangiogram to identify the site of chyle leak. And if they're already going to access the duct, which tends to be the most difficult part of the procedure, and they're already there, then they might as well do a thoracic duct embolization. If they're operative candidates, then they do tend to go back to the operating room for a VATS with a thoracic duct ligation. When there's a high volume chylothorax, these are patients that actually have better benefit from thoracic duct ligation. So the first question is, are they reoperative candidates? Their comorbidities, do their postoperative state allow for a repeat surgery, and how challenging is it going to be? If they are, then the first recommended option is a VATS with thoracic duct ligation. And you can consider pleurodesis, though it's not routinely recommended. But when they go in, and if they cannot identify the site of the chyle leak and they feel that they may not have achieved success, that may be the subgroup of patients where you can do pleurodesis to enhance the efficacy of the procedure itself. If they're not thoracic duct ligation candidates, then the only option left again is to do a lymphangiogram and attempt a thoracic duct embolization. And as we saw previously, it is a pretty good success rate for those subgroup of patients, so a reasonable alternative for patients who are either not candidates or have failed a thoracic duct ligation. When we talk about blunt or penetrating trauma with chylothorax, again, these patients are going to get a tube thoracostomy, in the emergency room when they're presenting with a trauma. If they have a pleural effusion, most of these patients, they're trying to rule out a hemothorax and end up with a surgical chest tube anyway. If they identify chyle leak, they will initiate conservative measures. And then unlike patients that are post-surgical, the difference here is that, the team does not really know where the leak is coming from. And so either they can pursue MR lymphangiogram, but most places don't have the ability to do that. And so most of these patients will get a lymphangiogram. And if they're going to, again, go in and do the lymphangiogram, it makes sense to then attempt a thoracic duct embolization at the same time. And if it was unsuccessful, then the next option, if we can identify the site with the lymphangiogram, is to then attempt a VATS with thoracic duct ligation. And then again, the same concept of pleurodesis, depending upon the site of injury or how many sites of injury they are, and what their success rate is in terms of doing a successful ligation. Let's move on to the more challenging aspect, non-traumatic chylothorax, and this is where it starts to get a little more nuanced. So non-traumatic chylothorax, you have a patient with a pleural effusion, you do a TAP, triglycerides are 120, you do a biopsy, the patient has a lymphoma. What do you do next, right? So these patients are going to have pleural drainage, and then you can initiate conservative measures. Tends to be MCT high protein diet, again, unlikely that you'll make them NP up front. And then you're going to assess the output, the chyle output. If it is a low volume intermittent, meaning that you do the thoracentesis and they're recurring 2 weeks or 4 weeks later, and you have identified that there is underlying lymphoma or malignancy, then the best treatment for them is disease-directed therapy. And if they get symptomatic from the recurrence of the effusion, then you can do drainage again. And again, these patients, the main goal is to keep them out of the hospital so that we can do disease-directed therapy. If it is low volume but persistent, it is hard to get these patients out of the hospital because they do tend to get symptomatic much faster. And so in addition to disease-directed therapy, which may be started as an inpatient, and that's what we do for some of our lymphoma patients, we then consider palliative options for these patients so that we can get them to treatment. And this may include either a pleural venous shunt, or more commonly used as a tunnel pleural catheter, or you may attempt a pleurodesis, though it's not very successful because the apposition tends to be hard to achieve because of the persistent nature of the recurrence of fluid. If it is a high volume chylothorax, again, the problem here is then you're going to have a significant amount of chyle loss from the tunnel catheter, because you're going to have to drain it pretty frequently, or high volume output from the chest tube. In those patients, it's reasonable, if there is expertise available locally, to do a lymphangiogram to see if we can identify the chyle leak and then pursue a TDE. And if it is successful, then we go back to disease-directed therapy. Even if it's partially successful and we can slow down the rate from a high volume to a low volume, intermittent or persistent, we can then supplant the disease-directed therapy with a palliative option till they have response to treatment. Again, lymphangiogram, if the leaks may be diffuse, so the success rate does tend to be lower as compared to postoperative chylothorax. And if all fails, then the only option left is to do a thoracic duct ligation. Again, as we saw earlier, the success rate tends to be lower because the leak is more diffuse. Surgeons will go and try to do a mass ligation and attempt a pleurodesis in the same patient. We have to assess if the operative candidates. A lot of these patients have advanced malignancies or have significant comorbidities, and so not very common to end up in the operating room for a VATS thoracic duct ligation with non-traumatic chylothorax, though it is a very reasonable option if you don't have a TDE option available at your institution. Last couple of lines on tunnel pleural catheters for chylothorax. So the only 2 studies, we do tend to use them. So I encourage all of you to, if you're placing tunnel pleural catheters for chylothorax, to aggregate the data, because not a lot of number of cases, so we want to get all that data together. But the first study on the left from Fabian Maldonado, this was done at Mayo Clinic, which talked about the role of TIPC in patients with benign chylothorax. They had 11 patients. And you could see their pleurodesis, which was defined as autopleurodesis, was 64% of the patients. Again, the caveat here being that it is defined by removal of the catheter, which may not indicate true pleurodesis. And the median time to pleurodesis in that subgroup was 176 days. But the important thing to note was there was no adverse nutritional, hemodynamic, or immunological outcomes in that subgroup of a small number of patients. The study that was done out of MD Anderson, this was TIPC, where they compared patients who had received TIPC for chylothorax to patients who had received other interventions, other pleural interventions, and makes sense that the patients who had TIPC did not require further pleural interventions. But what was interesting to note was that the decline in albumin levels in those 2 subgroup of patients, so TIPC versus patients getting other pleural interventions, was not very different. And once the TIPC was removed, albumin levels tend to recover in that subgroup of patients. So what did we recommend? Well, we recommended that you can use palliative options, TIPC being one of them. The caveat there is that unlike dogma, you do want to do symptom-guided drainage in these patients. You don't want to drain these patients every day or every other day, just to achieve pleurodesis, because you're going to have a significant amount of chyle loss, especially if they're getting underlying disease-directed treatment. And the other thing is, if your recurrence rate is extremely low, so I have patients that are recurring every month, every 2 months, every 3 months. In those subgroup of patients, it may just be reasonable to do, serial thoracentesis till we get the disease-directed treatment to work in that subgroup of patients. So to summarize, conservative management includes dietary measures, MCT diet with escalation to all the way up to TPN, and it's really based upon response, works much better in postoperative patients, but reasonable to try in non-traumatic chylothoraces. Limited data to support pharmacologic therapy. If you're going to consider it, octreotide, again, better data comes from the postoperative subgroup. Definitive management includes thoracic duct ligation and TDE, so you do want to assess if you have those expertise, especially the TDE expertise available at your institution or an institution near you. But the first line of intervention really depends upon the etiology. Traumatic tends to be better served with thoracic duct ligation versus non-traumatic. You may pursue a thoracic duct embolization. Operative candidacy, local expertise, and of course, the most important thing is you don't want to not make decisions unilaterally, but involve the entire group of experts that are going to be managing this disease state. Palliative interventions such as IPC, pleurodesis, and shunts are for patients that are either refractory to definitive interventions, or for those with non-traumatic chylothorax where there is low output, and therefore you're waiting for disease response and you're just trying to control their symptoms. And when we are considering palliative interventions, you can consider intermittent thoracentesis for recurrence, which is not very quick. If IPC is played, we do recommend symptom-guided drainage rather than the dogmatic drainage, just to make sure that they don't have a significant amount of chyle loss. I'll be happy to answer any questions and get into the discussion of this.
Great. Thank you, Abhi. Thank you very much for a very succinct talk about chylothorax, which is never an easy topic. So we've got some questions, and just to encourage other people to put all your questions on chat. So I think if I understand correctly, the question is any role for directly going straight to lymphangiogram or lymphangiocintigram and then do the embolization right from the same time?
So, I think that's a great question. I think one is, if you have expertise available, we don't tend to go directly to lymphangiogram unless it's a high output chylothorax, because, it's easier said than done. I very close to my IR colleagues, and it's by no means an easy procedure. It takes them hours and hours of time to identify, cannulate. And so I think for patients that have a high volume chylothorax, I think it's reasonable, especially non-traumatic. If it's traumatic chylothorax and, their surgeon knows where the site of chyle injury is, I think it really comes down to local expertise. If you ask the UPenn group, they will recommend everyone should go to TDE. If you ask, Mayo Clinic, everyone will get thoracic duct ligation, right? So you want to assess what the expertise present at your institution is, but not unreasonable for a high volume leak.
Yes. And I think we over the years kind of learned that there's a few little things that may make your investigations more fruitful. Can I ask, do you usually do your lymphangiogram from the groin lymph node injection or inject in between the toes?
Yeah, we do it from the groin. So our lymphangiograms, between the toes tends to be, you need to get the SCDs and make sure that the dye goes all the way up. So our radiologists, especially New York radiologists, I'm sure, they tend to access from the groin, and then they will, a lot of our subgroup of patients, even if they can't access the node, and something that I didn't talk about because data is so limited, is they will do something called the thoracic duct disruption. And so what they'll do is, if they cannot identify and they cannot place a coil, what they will do is basically they'll kind of macerate that area of the drainage pattern. And sometimes what you'll see is just with the lymphangiogram, just the oil-based dye that you're using for the lymphangiogram will actually lead to an embolization and cessation of chyle leak. So if you see a subgroup of patients in the studies where they actually didn't do the embolization, but they actually just got the lymphangiogram, some of the patients responded with cessation of or slowing of chyle leak. So, all of those variations are available, but we do tend to access it from the.
Yeah, I think I'm old, and so many years ago we used to do it injecting through the toes, and then it took us a while to realize that the dye just runs off because it's such a slow transition, especially if you've got lymphatic insufficiency. Then by the time it gets to the chest, the scintigram or the dyes is all run out. So since we switched to lymph node injection, that has been a lot better. But another technique-wise, do you feed them with cream or fatty milk before you do the lymphangiogram to try to enhance?
So we do try to enhance the leak itself. So what Gary's pointing out for the group is, if you have a fatty diet, and sometimes you actually do that even for diagnosis, right, where you have that borderline case, where you're not sure if it's not an obvious etiology. But yeah, what is going to happen is you're going to have increased chyle production, increased chyle leak, and therefore you will be able to better identify the site of the chyle leak. So yes, we do tend to do that. It's harder for outpatients because compliance on both ends of the spectrum is variable, but yeah, much easier for our inpatients.
Yeah, again, we've gone through a phase where we have already started people on no-fat diet, and then we send them to lymphangiogram, and that makes the interventional radiologist life very hard, very hard.
Absolutely.
Another questions here: how would you classify the chylothorax as low or high output? And then if you go for paradesis, would you have a preference of chemical paradesis or surgical paradesis?
Great. So I'll answer the first part of the question. And as Gary could tell you, this was a point of debate in our discussions, because if you look at the literature, it's very variable. When we did our first, pre-consensus statement evaluation, we had actually labeled it as 500 cc per day. But if you look at most of the surgical literature, it comes down to about 1,000 cc. And so again, it is the bedside clinician, right? If you're 980 cc's, is that going to be low output? Not really, right? The question is, if it's persistent and if it's in that range of 800, 900, 1000 cc every day, it's going to be high output. If you have something that is 100, 200 cc, you know that you can palliate these patients, especially in non-traumatic chylothorax. That's where the low output. So we leave it up to the clinicians, but we just to choose a number, because everyone loves numbers, we tend to use 1,000 cc.
And what types of pleurodesis would you prefer?
Yeah, so I mean, pleurodesis-wise, the data is mostly from mechanical pleurodesis, and it's basically done concurrently when they're going in. So when the surgeon is going in to do a thoracic duct ligation, and there are some studies that actually used chemical agents as well. I don't think there's a lot of data in terms of non-traumatic chylothorax and then pleurodesing them through the chest tube, using sclerosing agents, whichever is your sclerosing agent of choice. So if we have that subgroup of patients where we are attempting pleurodesis because the patient has a chest tube in a non-traumatic patient, just as you would for a malignant diffusion, that's when we tend to use sclerosing agents. But if this is, high volume chylothorax and they're going for a thoracic duct ligation, then they're, undergoing mechanical pleurodesis, the old Bowie pad and rubbing onto the pleura when they're in there.
The type of patients I'm sure most of the audience today look after are the non-traumatic chylothorax. Then a lot of times they are either related to malignancies or lymphatic insufficiencies where we can't really cure the underlying cause. So sometimes we got stuck with patients who can be managed on dietary things, but then we enter into some debate as to after a few weeks, the dietitians get cold feet and then say, how long are you going to keep this person on no fat? But I can't cure the underlying cause. So what do you do?
Yeah, I mean, those are, the bane of our existence, right? I mean, and again, easier if you have a patient with a malignancy, because they do tend to have some response to, or, usually extremely good response if it's a liquid malignancy like lymphoma, to disease-directed therapy. So those are the patients we tend to tide over to the point where, the main aim, we always say, is to not end up in the hospital, right? Because the problem there is that then you have to stop the disease-directed therapy, and it's a vicious cycle. And so they have more incentive. It's the ones that are non-traumatic from chronic conditions that tends to be much harder. And that's where, we talk about for LAM patients, sirolimus, and that's where our other subspecialists start getting involved in terms of what we can do to treat the underlying disease state. But I agree, I mean, it is, easier said than done. I can't go on a diet for 5 days. I mean, imagine doing that, days on end. So I think it's a challenge. Recommendations are recommendations. I think those subgroup of patients, I've done all of it. I mean, I had a patient with, chylothorax from a non-traumatic, non-malignant cause that we ended up placing an IPC that we only drained once a week, because that's what gave them quality of life. And that patient had IPC for, I believe, good a year and a half before she actually pleurodesed. So that's where you have to see what options and take the patient preference into account.
Yeah, I think that's very true, because that's a very good point, because the more frequently you drain it, the more it will form, because it takes away the back pressure to reduces the formation rate. So we kind of scare the patient by saying the more frequent you drain, the faster you may die. So therefore, we try to tell them not to drain too frequently. And I think sometimes anecdotally, patients tell us that they have been compliant, but when we retap the fluid, the triglyceride was just equally high, and then we know that that's not actually the case. It's happening at home. Yeah. Do you think that you do anything different if it is pediatrics? I know the consensus was on adults. Yeah.
Yeah, I mean, when I speak to our pediatric colleagues, I mean, theirs tend to be, more associated with congenital, like disease disorders where it tends to require more surgical interventions. I mean, I don't have a lot of experience in managing pediatric chylothoraces, but I do know that from the data that we have that they tend to be associated with, more congenital disorders. And so it tends to be either a more definitive intervention is available, or there is literally not much to do. The options become limited. I've seen our radiologists attempt embolizations in those patients as well. But, I don't have a lot of personal experience with peds, unfortunately.
And then another online question, which I think I'll modify slightly. So if the patient has got chyloscitis as well, how are you going to modify your entire approach?
Yeah, so I mean, this is the elephant in the room, right? Chyloscitis, and for the audience, I mean, when you have a chyloscitis, the management could be very different. If you read the consensus statement in detail, for all of those who read introduction, we specifically talked about that, where This does not extrapolate to chylosociety, because you can imagine if you attempt a thoracic duct embolization, all you've done is now actually taken away the forward flow. And if anything, your chylosociety is going to get worse, right? And so, and the other caveat in those patients is the chylothorax actually a hepatic hydrothorax mechanism of the chylosociety going into the pleural space from negative pressure, or is it actually truly a chylothorax from a chyle leak into the thoracic duct? So, you know, we do tend to account for that. I mean, again, disease-directed therapy tends to be more commonly used. We don't, I think thoracic duct embolization is, you have to be extremely careful in those subgroup of patients. And it is, again, much harder to manage. You know, in that subgroup of patients, chylothorax, which is already hard to manage, chylosociety is much harder. But the principles of conservative management are pretty similar. It's where the definitive intervention gets a little more tricky.
Yeah. And maybe the last question, do you keep the patient new by mouth after paradesis for a number of days to try to minimize the output?
Yeah. Yeah, so with the thoracic surgery patients, you know, they do tend to become NPO and, you know, to all the spectrum of TPN. You know, we don't usually paradese a lot of patients for the non-traumatic ones. So for the traumatic ones or the postoperative ones specifically, they are NPO and, you know, again, the spectrum all the way for two reasons. One, if they've done the ligation, they want to make sure that there is not a high flow through it. And second, if they've done a pleurodesis, especially if they've done a mass ligation or, you know, a couple of sites where they're not really sure where the site of exact leak is, or there's more than one leak, you do want to make sure that they achieve apposition. So we do try to keep them NPO, again, easier to control. Most of these post-traumatic patients are in the hospitals, so much easier to control versus the non-traumatic patients. You know, if they're not here, then it's much harder to achieve that.
Excellent. So I think we're right on half an hour. So let me thank Abhi again for taking the time to talk to us about chylothorax. Our next session is actually the first Wednesday of January, is actually January the 1st. So we're going to postpone it for 1 week. So the next time it'll be January the 8th in 2025. And Alice Rossman is going to talk about new toys in pleuroscopy. So in the meantime, I wish everybody a Merry Christmas and a Happy New Year, and we'll see you in 2025. And thank you, Abhi, again. Thank you.
Thank you, Gary. Thank you all.